So most of you know me. I am Dr. Stacy Fairbanks. I'm the residency program director here in our department. This morning, I was asked by Dr. Ebert to discuss our residency as a whole and specifically the curriculum. And our curriculum has a lot of different parts. So what I thought I would do is discuss some of those parts in a little more detail, but give a really broad overview of the residency experience here at MCW. As well as discuss our ACGME survey results from this year's survey and some goals that I have for the future. So my objectives today will be for you to be able to identify some key aspects of the curriculum, determine ideas for further educational contributions, and importantly, be able to find ways that you can personally support the educational mission of the department. Let's start with our ideal resident. I think that we can all picture our own ideal resident in our head. It doesn't really matter what this person looks like, but what their traits are. We think of our kind of ideal residents as having qualities like professionalism, trustworthiness, being enthusiastic, asking for and accepting feedback. In reality, it's our job to try to choose these people with recruitment who have kind of an innate drive to develop into what we consider an ideal physician. Our residents don't always come to us packaged in a way that has every ideal trait we're looking for, but the real ideal resident does come to us with some of the values that we can't teach or train. And by training in a supportive and educationally driven atmosphere, they then learn to gain the additional traits that we admire and seek in a physician. So once we match a resident, what is their experience like at MCW? Today, I want to walk you through the majority of the aspects of our curriculum, pointing out some of the ACGME and ABA requirements, some of our own strengths and opportunities, and the data we have in support of some of the things that we are doing here at MCW. As I discussed, we'll also visit the ACGME survey data for our specific residency. So all of this starts on match day, which is usually around St. Patrick's Day every year when a resident opens their envelope, or now it's actually an email, and it says, "Congratulations, you've matched it in anesthesiology at the Medical College of Wisconsin." Leading up to that time, myself, as well as all of the education staff and many, many faculty are working hard to recruit residents. So October, usually, it's August 1st, and I'm already working closely with Nate to work on recruitment. But October through February of each year, many people in our department are busy recruiting residents. Similarly, all of these applicants are choosing where they want to train. And there was a great study out of Mayo that shows what residency applicants say that they are valuing the most when they're searching for a residency. And two factors kind of stand out above all others when residents choose where to train. They look at the quality of the clinical education and the departmental commitment to education. So when I consider our curriculum content, much of what was in place prior to my arrival is still there. And there are some concepts that stand out and can be highlighted. I don't know that everything was done intentionally thinking of these concepts. However, going forward, that is my goal, is to be very intentional with the changes we make and think about how this affects our residents. So the first thing our residents, or the first thing that I think of when I talk about our curriculum is exposure. And the second are some of the adult learning theories. So regarding exposure, educational studies show that exposure to a subject or an activity early in residency increases engagement of residents in that activity throughout residency and then likely beyond in their career. I previously discussed this and showed this slide at our community engagement grand rounds. And the hope at MCW is that early exposure to multiple aspects of being a well-rounded physician will lead to increased engagement later in residency and then in that resident's future career. So while one resident might be attracted to and engage in research that they're exposed to in their intern year, and another might be more highly motivated to be part of physician advocacy and another in diversity and equity aspects of medicine. Of the multiple learning theories that exist, there are two that come to mind most readily when examining our own residency experience. The first is that of spaced repetition, and the second is the self-determination theory of motivation. Spaced repetition is an evidence-based learning technique that's usually performed with flashcards. Most of the current residents, and then many junior faculty will remember the highly popular OnKey program, which is used for studying for USMLE exams. I didn't have OnKey when I was a medical student, but what the program does is that newly introduced and more difficult flashcards are shown more frequently, while older and less difficult flashcards are shown less frequently in order to exploit the psychological spacing effect. And the use of spaced repetition has been shown to increase the rate of learning. So while our residency doesn't use flashcards, we do introduce multiple core concepts that we cover repeatedly during the residency. So for example, we might cover arterial blood gases during academic half day, both as CA1s as well as CA2-3s, again, via question of the day in practice oral boards and then in simulation. So each time this is visited, the resident expands their knowledge of the topic and gains a different or a deeper understanding. The self-determination theory of motivation represents kind of a broad framework for the study of human motivation and personality. It wasn't originally developed or thought of to just focus on education, but it centers around the idea that humans are born with tendencies toward growing and mastery. So if a person values a skill or a concept and internalizes it, then they'll learn and practice it to a higher level. In an attempt to simplify and apply the theory, which isn't really easy, I think of it as kind of by gifting our residents competence. So self-determination theory has three main parts. They're considered humans' three basic needs: competence, autonomy, and relatedness. And so by gifting our residents with competence in a subject, such as introducing them to a problem like an OB-focused problem in a workshop prior to them doing an OB rotation as a CA1, then they can gain autonomy to practice that skill and take more ownership of it clinically when they experience it. And doing this in the classroom with their peers also helps establish relatedness or relationships with others. So these types of learning activities throughout the curriculum will promote intrinsically valuing learning the subject of whatever anesthesiology subject a resident is trying to learn. And as a resident begins to feel more competent and autonomous, they become more invested in anesthesiology as a whole and learning what they need to know to take good care of their patients. So back to our resident. They matched in March. There are several very long months, and then they start their intern orientation at the end of June. All residencies begin with an orientation. It involves, our orientation in particular involves a lot of team building, expectation setting, and laying some rules of engagement for being part of the MCW family. We've also implemented implicit bias training during intern orientation to help our residents be able to be aware of their biases as they take care of a diverse population during their intern year. The ACGME clinical requirements of the intern year are really simple. They include 6 months of inpatient medicine of some type, a month of emergency medicine, and 1 to 2 months of critical care. For our residents in particular, they do their medical ICU rotation at Freighter. They usually have a month of chronic pain at the VA or pre-op clinic at the VA or Freighter, and 2 months of anesthesiology. Also during intern year, each intern does a professional development week. We did have a different grand rounds on this, but this was created in the last academic year by Dr. Zundel, and it removes the intern from the clinical work for an entire week with kind of 3 main goals in mind: increasing the understanding of Milwaukee as a community, particularly the medically underserved, participating in community outreach activities, And then importantly, developing skills that are traditionally minimally emphasized in the clinical setting. Things like conflict management, interpersonal communication, professionalism, social determinants of health, etc. So why have a professional development week? One of the educational studies that's out there is actually has Dr. Ehrenfeld as one of their authors out of Vanderbilt. And they asked residents what they value or whether there's a need for professional development. And residents expressed that learning about non-clinical topics that affect their profession and their patients' experiences highly matter to them. Here are just some photos of our residents doing community outreach during Professional Development Week. When we surveyed our own residents, 100% of them felt highly valued by the institution and the department by having this week, and they all felt that they learned a lot of skills that can't be taught on wards or in an operating room. Also during intern year is our intern lecture series. So in January of the intern year, the residents begin their series. This is an introduction to core topics and clinical scenarios in anesthesiology, and this occurs weekly, organized by Dr. Zundel. So I will say that for most anesthesiology residents, intern year is not their favorite year of training. I think that's probably good considering we want them to be anesthesiologists and not internal medicine doctors, but we do have a great intern year here. And after a grueling 12 months of medicine wards and other non-anesthesia rotations, the residents finally begin to focus on anesthesiology. Again, there's another orientation which covers a myriad of topics, including OR prep, meeting the chiefs, team bonding, learning all of the resources we have within our department at MCW, class goal setting, getting to try drawing up drugs and really practicing the skills that they'll use in the operating room prior to beginning. And then a VA airway skills workshop led by Dr. Zundel, Navalia, and Dolinsky. After the orientation, the residents begin CA1 year, which includes a CA1 boot camp. This year, we tried a new approach to boot camp and used open source material, which mostly consisted of University of Kentucky videos. These videos have a lot of beginner topics that are important and have been identified as an excellent source of knowledge. Another advantage of using the videos is that we weren't pulling much needed faculty from the operating room to teach every single day, and the residents could revisit the information in their own time as often as they needed in order to really remember the information that they will then apply in the operating room. Each recommended video was accompanied by a worksheet covering core topics that was developed by an MCW faculty. The residents then met weekly with a faculty guide to discuss the videos and the worksheets and answer any questions that they had. Overall, this was very positively received, and we may further develop it a little bit for next year, but it seems like a very good model for introducing our residents to the operating room, especially now that we are introducing them in a more phased manner, starting with several residents starting in the OR in May. The CA1 clinical rotations begin with a very heavy emphasis on the general operating rooms. We try to pair CA1s with a resident or an attending for several weeks as they gradually gain independence and autonomy. Other rotations then begin usually around November of CA1 year, and they include things like children's cardiac neuro, pain, RAPS, ICU. Dr. India worked very hard this year to create a track schedule for CA1s where they were offered an opportunity to identify subspecialties of interest in order to prioritize their exposure prior to fellowship applications. So that's been really wonderful. Also during CA1 year, we host a series of workshops utilizing simulation-based education in relevant topics that the residents will encounter during their CA1 year or early CA2 subspecialty rotations. I specifically wrote down all of the faculty who lead these workshops because they volunteer their time and their efforts, and the workshops are very highly rated by the residents each year. The CA1 curriculum is organized by Dr. Willie and has multiple faculty discussing basic exam topics, mostly using Anesthesia Toolbox as the most common reference. We also incorporate topics during CA1 year, such as professionalism, diversity, equity, and inclusion, with the speakers recruited by the DEI committee, regional wellness, and then a basics of QI and some exam prep. One of our newest parts of the curriculum is the professionalism series led by Dr. Gross. This was a new initiative introduced last year. He really spearheaded this. He came to me and said, hey, I think that we have a need for this and I'd like to do it. And he took it and ran with it. This addresses an ACGME core competency and was a previous gap in the curriculum. The ACGME says that residents must demonstrate a commitment to carrying out professional responsibilities and an adherence to principles. There are many things that the residents are expected to demonstrate, and many people will argue that we can't teach professionalism. The guiding principle of the professionalism didactic series, however, is that it can be fostered by increasing empathy. And there are many studies that show that empathy declines during medical training and throughout our career. And so we actually have been able to see that structured curricula have been shown to increase empathy, and that clinical performance in attending anesthesiologists correlates with measures of empathy. So while some people argue professionalism can't be taught, I think Dr. Gross and I would argue that it can, and we're doing our best to do that during intern year. He did this by having a series of 4 didactic sessions that included an intro, a discussion of difficult professional situations, a discussion of second victim syndrome, and a very well-received session where a patient with a traumatic anesthesia experience came and shared her story and discussed medical PTSD. Also included in the CA1 curriculum is a half-day workshop on regional anesthesia developed by Dr. Castro. The half-day curriculum for regional anesthesia actually starts in CA1 year, but will be continued in the CA2-3 years. Dr. Castro developed all of this, again, kind of single-handedly with the help of some of her RAPS colleagues. The half-day workshop for the CA1s was held in the STAR Center and had just a very brief didactic, and then the residents were split into small groups and they got to practice on a standardized patient. The residents really enjoyed this workshop. 100% of them rated the workshop as extremely effective or effective. And there were a lot of very positive comments on just how great this workshop was with setting the tone for using ultrasound and practicing prior to starting RAPS. I asked Dr. Castro to do a little SWOT analysis on her half-day curriculum, which was excellent. So when it comes to the institution of all of these new curricular aspects, we try to look at the strengths of the curriculum as well as the opportunities involved so that we can further refine them for the next year. The strengths for the half-day curriculum in regional was that the resident feedback was very positive and that the material applies directly to the ABA applied exam. A weakness was that we didn't implement the CA2-3 curriculum this last year. However, we are starting it this year. And I think it's perfectly fine to phase things in when we're working so hard for improvement. We are trying, just like we are with every single part of our curriculum, to decrease lectures like I'm giving right now, where you all sit in our passive audience and I just talk, and go to more active learning types like PBLDs and flipped classroom. And a threat is that coordination with other divisions is vital to make sure that we don't waste half-day time by redundancy. So while we may want to have this spaced repetition, we also don't want to repeat the exact same thing multiple times. So those are some of our key aspects of our CA1 resident experiences. After the steep learning curve of CA1 year and a lot of time in the general OR, a resident moves on to the CA2 3 years. Most people in our department are familiar with the clinical ACGME requirements, but I thought I would cover them here so that it's very clear that we do have a lot of clinical opportunities. The ACGME requires 2 weeks in a pre-op clinic, and we give all residents 4 weeks. They required 2 weeks in a dedicated PACU rotation, 2 blocks of neuroanesthesia. These are also complemented by a series of problem-based learning discussions led by Dr. Galopati and her team. 2 blocks of cardiothoracic anesthesiology are required. We offer 2 blocks specifically of cardiac, as well as 2 weeks of dedicated thoracic time. Most of our residents say that they get plenty of cardiac opportunity here and that our cardiac service is getting busier and busier. ACGME requires 3 blocks of pain medicine. They further stratify this as requiring a block each in acute perioperative pain medicine, which we use as the CHIPS rotation, a block of inpatient and outpatient chronic pain, and a block of regional anesthesia. The ACGME also requires a total of at least 4 blocks of intensive care, which is satisfied by the VA SICU as well as the CVICU. 2 weeks of an out of OR rotation, which our residents do as the VA Safari rotation. At least 2 blocks of pediatrics, which our residents typically do 4 to 6 blocks, and 2 blocks of OB. Our residents also do general OR rotations at Freighter, the VA, and they spend at least 2 weeks at Freighter at Menominee Falls, where they get to learn a little bit of practice management and also do blocks and spinals. Some of the major improvements in our clinical rotations in the last year include Dr. Haas's dedicated curriculum building for the PACU, as well as the anesthesia resident in charge rotation, which includes 360-degree evaluations. And then a new CVICU curriculum spearheaded by Drs. Fierro, Hang, and Mocker, which I'm very excited as they develop this. I think that it will really help with the learning in the CVICU for the residents. In the last year, we've also increased our elective time from 2 weeks to 6 to be more commensurate with other residencies across the country. We formed several new electives, including an education elective, a point of care ultrasound elective that Dr. Kapelis actually developed during his education elective and during his last year. 3 different pediatric subspecialty rotations, a non-OR anesthesia rotation that Dr. Lauer developed to occur at Freighter, and then a new and improved research rotation that Dr. Roberts has been working on. Additionally, Dr. Richardson has a newly developed global health rotation that she has been working on. And I know that Dr. Kapelis has further ideas for electives this year too. In addition to our clinical rotations, the CA2 3 years also have a dedicated curriculum that occurs on the 3rd and 4th Wednesday of each month. This really includes many topics: QI, M&M, TEE, which of note, we do have a need for a new TEE champion this year, if that interests anyone, as well as time dedicated to diversity, equity, and inclusion, POCUS, practice oral boards, and then study halls for the residents. I also wanted to take this opportunity to highlight Drs. Pinkerton and Muravieva. Dr. Pinkerton has really been our QI champion for many years, but she's a fellow now. I don't know if she's on here or if she's starting a cardiac case, but she has kind of handed over her baton to Dr. Muravieva, who will be leading our QI efforts now as we work to kind of improve that and really focus on QI in the next couple of years. This past year, we had a new and high yield and very well received point of care ultrasound curriculum developed by Dr. Jaranek. He's worked really hard to fill what I think was a major void in our residency. Prior to this, there was no formal curriculum for POCUS, despite this being a very highly tested on topic in both the written as well as the applied exams. The main objectives of the curriculum are to help residents answer high-yield board and OSCE questions correctly, and also learn how to obtain and interpret standard POCUS views for clinical practice. The ABA even includes POCUS in their content outline, stating that residents should be able to obtain and interpret cardiac, lung, and gastric views after residency. And I can say from sitting on the senior exam, the advanced exam committee, that we are editing a lot of questions on POCUS. So I know that the ABA is trying really hard to increase the number of questions they have on the exam. So it will be really important that residents learn this. The POCUS curriculum includes 3 different modules comprised of a pretest, a short lecture, and then small group stations for practice. This year, the introductory year, the curriculum received rave reviews. 100% of residents found this activity extremely effective or effective. And in the coming year, the POCUS experience will be expanded to 5 modules. Dr. Kaplis has worked with Dr. Jarenick to help improve this, as well as add the POCUS elective to complement this opportunity. So I think those 2 things together will really increase our education in point of care ultrasound. Simulation. I wasn't able to draw a ponytail on Dr. Pugh. Dr. Pugh, I'm sorry, I'm not representing you accurately here, but Dr. Pugh is our simulation champion, and he spends a lot of time each year providing residents this opportunity. So they all get the opportunity to participate in simulation several times per year. Dr. Pugh facilitates this, and this transcends all 3 years of anesthesiology residency at MCW. It's an ACGME requirement for residents to have 1 simulated clinical experience each year. So I'm really proud to say that our residents end up experiencing at least 5 simulations per year, if not more, between Dr. Pugh's efforts and our workshops and other half-day scenarios. So by the end of residency, residents will have been exposed to 25 to 30 crisis scenarios, and they're being prepared to successfully complete the OSCE portion of their ABA applied exam. Another experience that all of the residents get is journal club. We're very privileged to have Dr. Roberts leading our quarterly journal clubs. This is a reminder that all faculty are invited to journal clubs, so please join if you're able. I think the residents always appreciate input from our faculty experts. And right now we're still virtual, but we are hoping to move back to an in-person platform soon. Another aspect of the residency that's unique to MCW is Dr. Drexler's question of the day. I don't think people realize that just answering 1 question every day is a key component to the spaced repetition that's used to reinforce key concepts. Dr. Drexler looks at the most missed ITE items, as well as the ABA content outline to develop her questions, and she puts a lot of time into this, and then it's emailed daily by Aaliyah Hayward. All residents are also exposed to advocacy. This is an effort led by Dr. Connolly. The residents have an advocacy dinner during their CA1 year. Right now, this occurs during Professional Development Week. And then the residents who choose to heavily engage in the Wisconsin Society of Anesthesiology and the ASA are excellent at continuing to educate their colleagues on important challenges in our field. Importantly, and this is something I'm very proud of, our residency has now had 100% resident participation in the ASA PAC for 2 years in a row. This is a really huge accomplishment, and it's an important measure of resident engagement overall. It also puts our residency on the map from a national perspective, and it's really a testament to the hard work by Dr. Connolly, as well as the Wisconsin Society of Anesthesiology affiliated residents. Some of our leaders like Dr. Yale, Dr. Bites, and Dr. Choksey and Chalewa really help keep the residents engaged in this important effort. By the time they graduate, nearly every resident has participated in the Midwest Anesthesia Resident Conference at some point. Our department has exhibited tremendous support for our residents to attend this conference in April every year. This is usually led by a faculty team of Doctors Diaz, Meineke, Kula, and Muravieva. And our residency is known for representing our institution very professionally while also bringing home a majority of the hardware. In listening to all of the aspects of the residency experience, it might seem as though we focus really very little on anesthesia. This is far from the truth because our residents dedicate 70+ hours per week mastering our field clinically. But it's really crucial that we focus on resident wellness and work-life integration as well as the clinical side. So why is wellness so important, and why do I talk about so many things other than just anesthesia when I look at our curriculum? Oh, I don't know if you all can hear me right now. I have the spinning wheel of death, so I guess we'll just pause for a moment. Okay, can everyone see the next slide?
Yes, and can hear you.
Okay.
Yes.
Yes.
So studies originating from Mayo Clinic show that 51% of residents and first-year residency grads, whether they pursue a fellowship or go into private practice, experience burnout. 32% of them exhibit what's considered distress at some point, and 12% demonstrate signs of depression. This graph shows the percent burnout in CA1s through fellows in the study that was done at Mayo. And it shows that burnout is prevalent at all levels of training. It's also important to note that women are more likely than men to suffer from burnout, distress, and depression. This is thought to be due to the high numbers of microaggressions and other unseen kind of battles that women residents have to experience during their residency. So what caused burnout in these studies? Maybe not surprisingly, it had to do with work hours and student loans. So working more hours per week was statistically significantly associated with a higher risk of distress and depression, with a 3% higher risk in both of those for each additional hour worked. Owing student loans was statistically significantly associated with a higher risk of both distress and depression as well, with a 1% higher risk for each additional $10,000 owed. Interestingly, things like taking night calls, being in a committed relationship, the number of kids someone had, or speaking a language other than English was not associated with these factors. And two big things really was associated with a lower risk of burnout, distress, and excuse me, I'm sorry. Dr. Lauer's calling me. So two factors were consistently associated with lower risk for all three of these outcomes. So that was the perception that the resident had of whether their workplace provided sufficient resources to address burnout and depression, but also whether they felt comfortable using those resources. And then whether the resident perceived that they maintained a balance between their personal and professional lives. If you look at all of this data and put it together with data from other previous studies, there's one really important thing. And honestly, I think as faculty, if there's one thing that you remember from this talk today, really as residents too, but it's that 23% of anesthesiology residents who screened positive for depression during these studies thought about or wanted to commit suicide at least some of the time during their residency. And these data, the data in this Mayo Clinic study actually corroborated past data, suggesting that approximately 3% of all US anesthesiology residents have thought about committing suicide. So in a large department and a huge institution, when we have production pressures and stress with our patients, just remember that everyone has their own shoes that they're walking in, and do everything you can to be kind to one another So what are some ways that we check on wellness? In our department, there is a MCW website for residents to log on to and assess their own burnout scores. We do require fatigue modules yearly. We have quarterly mentor meetings for check-in, as well as twice yearly program director meetings. Many of our residents and attendings are trained to be an SOS peer supporter. And we try to have them reach out to residents after OR deaths or bad outcomes. And then we have site champions because this is a large residency. So when people are at Children's, Dr. Lebowski is always really watching out for them. And similarly at the VA, Dr. Iqbal is very closely monitoring the residents. And then in terms of ways we foster wellness as a program, we do offer wellness sessions during academic half day. These were not very well received in the last year by residents, so we are restructuring that. But the important thing is that we're trying to offer tools that residents can use now and in the future to improve their wellness and increase resilience. We also have the Community Engagement Day at All Saints, which the majority of residents say actually highly improves their wellness. We have class-specific day retreats, which we'll talk about shortly, as well as numerous social activities. We've also really worked hard to give residents a little bit more predictability in their schedule while rotating at Freighter by giving post-fourth call residents the day to not be responsible for a specific OR and instead to give breaks to their colleagues. So what about our retreats? Last year, our CA1 retreat included learning how to teach others in the operating room setting, and then the residents taking a Milwaukee riverboat ride. Again, the residents responded to this very well, saying that the retreat made them feel valued by the department and the institution. And I think this is a very important step in creating wellness as well. Each of our classes have a single day retreat throughout the year. So for the CA2 single day retreat, they visited the Anesthesia Wood Library in Illinois, and then successfully avoided the sinking of the Titanic at an escape room. The CA2s also have a tradition of having a weekend retreat at Blue Harbor Resort in Sheboygan. The department is very supportive of this and really has dedicated, I believe, money for many years for this retreat. So we did wellness activities this year. Dr. Albright had a negotiation and boundary setting talk that was excellent. We also set up a job fair where multiple private practices from Wisconsin as well as Iowa came and talked to the residents about recruitment. The residents could apply for jobs with them, but also just discuss what people are looking for in job applicants. And then we had a great panel on private practice versus academics. We're hopeful to be able to implement a CA 3-day retreat this year, barring any unforeseen COVID restrictions. So I've discussed a lot of the curriculum, and it's clear that we have a targeted and intentional curriculum that is becoming even more so. But we get the opportunity to survey residents each year, and in many ways, we have a MCW survey. We have an internal departmental survey, as well as exit interviews for our seniors. And then we have the ACGME survey, which is extremely important. And a lot of the results of the ACGME survey then result in whether the ACGME cites us for anything, does site visits, or keeps us as an accredited residency. So I consider one of the most important ways in which we receive feedback to be the ACGME survey. And the ACGME survey results this year highlighted many areas in which we've shown overall improvement in the last 12 months. First, I'm going to talk about the resident feedback on the survey, and then we'll discuss the faculty survey. The residents showed that we have improved in areas like education. So they say that we've gotten better at not compromising their education with non-physician obligations, that they're getting more protected time to participate in structured learning activities, that we effectively emphasize a culture of patient safety, that the quality of our teaching received in clinical and didactic activities is improving, that our educational content overall is improving. That was a positive improvement on 5 or 6 questions on the survey, that they are taught about healthcare disparities. Again, on the ACGME survey, there were several questions asking about diversity, equity, and inclusion efforts within the department, and all of these questions showed an improvement. And then the overall evaluation of the program was highly improved compared to last year by the residents. I do want to take this opportunity to talk about the anesthesia half days that we have. We've now had anesthesia half days for 1 full year. And I realize most of the people on the grand rounds this morning are from Freighter, but our residents rotating at Freighter, CMH, the VA, and Children's all attend half day. And I am really proud to say that in the last year, we have had 0 residents miss a half day because they had to stay and provide clinical obligations. There have been a couple of times where the offer was there due to a huge index case and the residents chose to stay and work clinically, but we got every single eligible resident out for half day for an entire year. And that is a huge accomplishment. And everyone should be proud that our department worked together to achieve that. So while we improved in many areas, the survey also highlighted some areas of opportunities. Of note, our program scores did not meet the national standard in some of the following areas. The impact of other learners on the residents' education. We know that we have a lot of learners in our operating rooms. And I think this is a problem everywhere, but unfortunately, we were a little bit below the national benchmark. An appropriate balance between education and patient care. Several areas of professionalism went down in terms of our percentages, including that the residents note that they may not always feel encouraged to feel comfortable calling their attendings with questions or able to raise concerns without fear of intimidation or retaliation. There were about a quarter of the resident survey answers who stated they had personally experienced abuse, harassment, mistreatment, discrimination, or coercion, or had witnessed such things. We have concern for information loss during shift changes, and then that a culture of our institution reinforces personal responsibility for patient safety. So I think all of these are things to think about, and I know that I'm working really hard to help improve some of the culture that may have caused some of these things to decrease. What about the faculty? What did they say on the survey? They also indicated several improvements. These included that many faculty participated in faculty development or scholarly activities in the last year, that the residency effectively emphasizes a culture of patient safety. This was also highly rated on the resident survey. Program director effectiveness was high and improved, and then all of the diversity, equity, and inclusion questions were improved. But still didn't really meet the national benchmark for DEI in terms of the faculty. And then the overall evaluation of the program was increased in terms of being seen as very or somewhat positive by the faculty. So what were the opportunities that our faculty noted? The faculty noted a dearth of the ability to participate in faculty development that had to do with fostering resident well-being. They noted dissatisfaction with professional development and education overall, dissatisfaction with the way in which they were evaluated. And then they didn't always feel that graduating residents are prepared for unsupervised practice, and that the learning environment is not conducive to education. So these are all things that I think leave us plenty of room for improvement for making sure that we have an excellent training environment going forward. So looking forward, knowing what we know about the ACGME surveys, the MICWA surveys, and ABA requirements, how do we look forward to give our residents the best experience? First is the short term, or what I like to call the low-hanging fruit. We have some easy things we can do to improve our program that we're working on, but all of these things take time. This includes things that are already in progress. So we've hired 3 new associate program directors that all have a bucket and a goal that they are working on, as well as a PhD educator. And they all have targeted areas of focus for program improvement. We have a plan for improving resident evaluations and further developing the curriculum, including incorporating more point of care ultrasound, a more rigorous M&M process in terms of the residents presenting M&M, more resident-led teaching in the senior years in the didactics, and then increased emphasis on feedback for both the residents and the faculty. Additionally, Doctors Roberts and Freed are working very hard to improve our research efforts for the residents. We have 3 junior residents who are getting dedicated research time just this academic year, and that will hopefully increase as we move forward. I think the more challenging aspects of program improvement is the higher hanging fruit, which will occur in the long term, but takes small deliberate efforts for years in order to show improvement. So this includes having just an overall lens for education and everything we do in the department. Remembering the importance that wellness has in the scope of residency. It includes improving OR culture and advocating for our patients and our residents when necessary. Decreasing reliance on residents as a workforce and instead focusing on their interests and their educational needs. Recruitment of diversity at a faculty level, not just a residency level, and then retention of our residents as faculty. I would love to see more educational scholarship for both residents and faculty, and I realize that that's something that I have to lead and I'm working on. And I'm very excited to have Dr. DeSantis on the team as well to kind of help focus that effort. And then an overall improvement on board pass rates. In summary, this is a really great program with the potential to be even greater. And it's great because of a large group of individuals who've really dedicated themselves to the residents and to the department. So thank you, all of you, for everything you do. It takes a village, and we have a village, a really good village. So thank you, and I'm happy to take anyone's questions.
Dr. Fairbanks, I have a question. So this is the first time that we've done the phased approach and getting the CA1s in early. Any feedback on how that's done for like the level loading and stresses at the beginning of July that has happened in the past?
Are you asking for feedback on
Is it working?
whether
Is it going well or not going well? That's kind of the...
Yes, got it. I think that the feedback I've received is that it is going very well. I don't know that the residents feel comfortable giving feedback, and we don't have senior residents who repeat. It's not like someone can say, wow, this CA2 year is so much easier in terms of a call load in July than last CA2 year. However, the faculty have said that it has really improved to not have 20 brand new residents, but to have a few less. And I do think, looking at the QGenda call schedule, that the call burden for the senior residents is decreased compared to last year. So I think overall it's good. I am planning to phase in our current interns in a little bit more of an aggressive fashion so that we have more than just 8 people who are done with their boot camp by July 1st in the coming year. But I think that so far it's working well.
Dr. Fairbanks, this is George Hoffman.
George.
I thank you for this overview of the learning theory and work that you and all the education directors have put into this is tremendous. I want to offer some words of encouragement to the current trainees. The time will go by in a flash, and this is your opportunity to think broadly and develop in ways that might not be directly related to whatever focus of anesthesia that you ultimately achieve. Some of you might be very clearly directed. Some of you might be less so. That was certainly my path, was more exploratory than highly directed, at least for much of the time. And there are so many great opportunities in this very broad residency program. And historically, the graduating trainees have looked back and given highly favorable reviews to their educational experience overall, and have performed by all accounts very well in whatever jobs that they have moved into, many of which are currently in our faculty. So I want to, this is supposed to be encouraging, take the long run, and thank you to all the faculty members and residents and support staff.
Thanks, George. And thanks for everything all of you do over at Children's. Well, I don't need to keep everyone longer than necessary, but thank you for signing on this morning. I know that July and August are very busy. If you think of other ways in which we can work toward those final goals I discussed, I'm always happy to hear them. If you think of ways in which you want to contribute to the program or the curriculum, I'd love to have you involved. And yeah, thanks so much.
Thank you.